So welcome back to pharmacology for our second session. In this session we're going to be concentrating on pharmacokinetics. So session one we looked at pharmacodynamics, how the drug actually exerted effects in the body, and this time we're going to focus on how the body affects the drug, what the drug has to go through and what the body is doing with the drug that's going to increase or limit the amount of drug that actually gets to the right target site in the body to be able to exert pharmacodynamic effects. Pharmacokinetics is going to relate a lot to dosing regimens, so how much drug we have to give, how often, and how we administer that drug. To work those things out, we're going to need to consider the pharmacokinetics of a drug. So we'll look first at routes of administration. There's lots of different ways you can give a drug, and these are going to affect the amount of drug that actually gets absorbed into the body, drug absorption, which is the first part of pharmacokinetics. Then we'll go through the other aspects of pharmacokinetics, that is the distribution of drugs, the metabolism of drugs, and the excretion of drugs. So looking first at these routes of administration, this figure here shows most of the different ways that we can administer a drug, and without even having every single way, it's lots of different routes of administrations being shown here. The most common by far would be oral administration, taking something by mouth and swallowing it. That would then be absorbed from the gastrointestinal tract. You can also access the gastrointestinal tract from the other end and have rectal administration, or you can give things by mouth without them actually being absorbed from the gastrointestinal tract, but instead through the mouth itself with sublingual or buccal administration. Sublingual being under the tongue. Buccal refers to a drug being absorbed from between the teeth and cheek. You can inhale some drugs. And then we have our injected formulations. The word parenteral simply means injected, but you can inject to different places. You can have intravenous into a vein, you can have intramuscular into the muscle tissue, or subcutaneous down into the fatty adipose tissue underneath the skin. Other injected formulations can include things like epidural, where you inject into the tissues surrounding the spine. And then you can also, for some drugs that have the right chemistry, that is, that are very lipid soluble, you can actually give them simply by a patch, a transdermal patch onto the skin, and let them diffuse through the skin and into the body that way. Other formulations are really about limiting access of the drug to most of the body and instead applying them directly where they're needed to treat something. So this includes topical formulations for treating skin conditions, applying them directly onto the skin, and ocular and otic formulations into the eyes or into the ears, where you're looking to get an effect at that particular site while limiting how much drug is actually getting around the rest of the body. Now, all of these different routes of administration are going to have advantages and disadvantages, mainly related to how much of the drug actually gets absorbed by that route of administration. So the different routes of administration are mainly chosen because of the absorption pattern observed by that route of administration. So orally administered drugs, you can have a very variable absorption pattern that's going to be affected by many different factors. It'll be different from one drug to the next and might even differ for the same drug in different situations. So there's advantages and disadvantages there. We still use orally most commonly because it's safest, it's non-invasive, it's very convenient for people to be able to administer their own drugs in this way, very economical way of distributing drugs. But you can get limited absorption of some drugs. Some things don't make it out of the gut and into the blood. Food and its presence can affect the absorption for some drugs. You rely on people taking the drugs themselves. And a point that we'll come back to a couple of times over the lecture today is that some drugs might actually get metabolized before actually reaching the systemic circulation. But more on that one later. Compare this to, say, an intravenous injection. This is where you're going to get absolutely all of the drug be absorbed, because we count a drug as absorbed in the body once it's in the systemic circulation, in the bloodstream. And so if you're injecting the drug straight into the bloodstream, there's no absorption process required. So you're getting all of the drug in the body. And as well, you can have very immediate effects come from this. So that can be useful for, say, pain relief in a trauma situation, getting the drug into the body immediately. And you can give even large volumes of drugs this way. But there is still disadvantages to this, because you can have most especially need for very strict aseptic techniques. There's potential for infection at the site of injection that you have to do a lot of careful control to make sure that that's avoided as much as possible. Now, there's other absorption patterns for our other routes of administration, each that come with various advantages and disadvantages. I'll just pick out a few key points, but I would recommend that at the end of the lecture, come back to this table and the continuation of it on the next slide and read through each of the points available, and you should hopefully have a good understanding of why those points are there based on what we cover today. So you've got subcutaneous, that's an injection still, but just in under the skin. So you will get a different absorption pattern then. It's going to depend a lot on how the drug is formulated. If it's already in a very aqueous or watery solution, it should readily access the body. But you can also use different formulations to slow down the absorption from that subcutaneous tissue into the bloodstream with various depot preparations. For intramuscular drugs, these are still injections, relatively easy to give. A lot of people are even able to self-administer intravenous injections. You just got to get into muscles, and if you pick a large muscle like the bum or the thigh, then you can get various depths of your needle and be pretty sure you're getting into the muscle. But it can be a painful way to administer drugs. Patches are useful because they can give a very slow and sustained absorption pattern, but a lot of drugs don't have the right chemistry to be able to be absorbed through the skin. Things have to be quite lipophilic. Rectal administration can be quite erratic, so basically whether or not you're going to be passing feces soon, how much feces are already present is going to affect how much drug actually gets into the body via the rectum. And you can have some drugs be quite irritating to the rectal mucosa. So it's generally avoided, usually where oral route would be preferred, but there might be some issue with the patient's ability to swallow or to keep down drugs in a vomiting situation. Inhalation is used mainly for where things want to be administered to the lungs themselves, so things like asthma medications, but you still can get drug getting into the bloodstream through the lungs. You've got very heavily vascularized tissue in the lungs. It's there to set up to get transport between air and lungs. And so you're going to get things into the bloodstream even if that's not your desired effect. We've got a few things that are gaseous when they're administered, things like some inhaled anaesthetics, and this is going to be the best route for administering those. Sublingual is going to depend on a few factors of the drug, so particularly if it's lipid soluble enough to get across the mucous membranes in the mouth. But for things that have that lipid solubility, you can get very rapid entry into the bloodstream by this way. And but you're going to have some disadvantages there in that you can have some variable amounts of drugs being absorbed depending on how much actually stays in the saliva in the mouth and then gets across the mucous membranes, and how much of the saliva containing drug actually gets swallowed, and then the drug would end up being administered via an oral route rather than a sublingual route. So come back and look at these different points in detail later on after we've been through all of the different aspects of absorption, and particularly when we talk about metabolism. You'll see mentioned on a lot of these first pass effect. We're going to be going through what that first pass effect actually is later in this lecture. So these different routes of administration are going to be affecting the amount of drug absorption. And drug absorption is one of our key aspects of pharmacokinetics. That is what our body does to the drug, or the ways that our body is going to affect how much drug actually reaches the target site and can exert pharmacodynamic effects. So how much drug is absorbed is going to depend on the route of administration and also the chemical nature of the drug itself. Is it lipophilic? Is it hydrophilic? How well does it cross cell membranes? Once it's absorbed, it's in the bloodstream, so this is a blood vessel here, and then once in the bloodstream, some of the drug will be freely available, dissolved in the blood and being distributed around the body and be able to leave the bloodstream and get to its target site of action, to get to receptors and things like that. But it's also going to be available for elimination, metabolism and excretion. So our four aspects of pharmacokinetics are absorption, distribution, metabolism and excretion. And we need to consider these when administering drugs because how much drug is given and how that drug is formulated is going to vary depending on these different aspects of pharmacokinetics, as well as what site of action you're trying to reach and the unique chemistry of that drug itself. So the absorption of drugs is our first one, and we actually have a measure of absorption that we can calculate for drugs, and that's called drug bioavailability. So our definition of drug bioavailability is a definition we like to test you on in the exam as well, so take note of it now, is drug bioavailability is defined as the fraction of unchanged drug reaching the systemic circulation following administration by any route. So it's a proportion of drug that actually gets into the bloodstream, and we measure it as a percentage of the drug administered. So if you were to give a drug by IV injection, bioavailability is 100%. You put the drug directly into the bloodstream and 100% of the drug is there. Following other routes of administration, it's going to be less than 100%. For example, following oral administration, bioavailability will always be less than 100% because you'll have factors such as incomplete absorption. Some drug might simply skip its way down through the gastrointestinal tract and end up in the feces without ever actually meeting the wall of the intestines or the wall of the stomach and being able to be absorbed. Some of the drug might get broken down in the gut and be metabolized there. And the amount of absorption across the biological membranes of the gut could vary. And then also this aspect called liver biotransformation, or what we call first pass elimination, is going to be very important in reducing bioavailability following oral administration. So this first pass elimination is very important to understand. It's one of the major determinants of drug bioavailability via the oral route. So via the oral route, there are two things that are going to mainly affect the amount of absorption and therefore that are going to affect the bioavailability. That is the amount of absorption and this first pass elimination. So the amount of absorption could be less than 100% because a drug might be too hydrophilic, water soluble to cross phospholipid bilayers, or it could actually be too lipophilic. So while it would be good at crossing the biological membrane, it doesn't dissolve very well in the watery environment of the gut to actually get to that membrane. You can also have some things that make their way into a cell lining the gut, but then get pumped back out again. We have lining our gut reverse transporters. It's one of our protective mechanisms against various toxic substances we might take in with food or water. A group of proteins called P-glycoproteins that are transporters that just pick things up that have been absorbed from the gut and pump them back out into the gut. And that could include some drugs getting pumped back out. But then we have this first pass elimination. This is going to, for some drugs, very drastically reduce the bioavailability. So for first pass elimination, what we're talking about is the fact that drug might get absorbed from the gut into the gut wall and then into the bloodstream, But all the blood vessels around the gut, if I show you this picture here quickly, all the blood vessels around the gut actually drain into veins that connect to become the hepatic portal vein that we can see here. So lining the stomach, the small and large intestines, including some of the rectum, all of the blood vessels that supply these tissues drain into this hepatic portal vein. And we call it a portal vein because it's a vein between two capillary beds. So this hepatic portal vein is called the hepatic portal vein because it goes to the liver. And in the liver, this vein breaks up into a second capillary bed and distributes all the blood that's just past the gut through the tissues of the liver. And the liver is our main detoxifying organ. That is, it's able to do a lot of drug elimination. So drug might get absorbed from the intestine, say here, but end up in these veins, end up in the hepatic portal vein, and then end up in the liver. That blood ends up in the liver. And while the blood is in the liver, the drug can be eliminated from the blood. After the liver, the blood goes into the inferior vena cava and back to the heart to be distributed around the body. So this means that drug can get absorbed into the hepatic portal system, but never actually reach the systemic circulation over here in the inferior vena cava, back to the heart and around the body. So we can see something like that here. Drugs in the gut lumen, some of the drugs simply won't be absorbed because of these factors that affect the extent of absorption. Of the drug that's actually absorbed into the gut, some of it might not make it into the bloodstream itself because of, say, P-glycoproteins pumping it back out again. And then of what gets absorbed into the portal blood, a proportion of that might get metabolized and eliminated in the liver, so that only a small percentage of the drug actually reaches the systemic circulation. And it's only the percentage that actually makes it past the liver that we consider bioavailable, that's actually able to reach its target site of action. So bioavailability by the oral route can be quite low depending on how much is absorbed and especially on how much is eliminated by first pass elimination on this first pass past the liver before it gets to the systemic circulation. So that means that drug bioavailability by the oral route can be as little as 5%. Some drugs we're really good at metabolizing in the liver, and so we might have only 5% actually make it to the systemic circulation. Some drugs we don't metabolize very well in the liver at all. Instead, they'll be close to, but not quite 100% bioavailability by the oral route. And this is going to vary dramatically from one drug to the next based on how good we are at metabolizing that drug and how good we are at absorbing that drug across the gut wall. Bioavailability for other routes, other key routes of administration will be different. As I said earlier, 100% for intravenous. We count a drug as bioavailable once it's in the systemic circulation. Intravenous, we're putting it there directly. Also, that gives us a really rapid onset. For intramuscular, the bioavailability is going to be quite high. We've got lots of blood vessels through our muscles, and most of the drug injected into the muscle is going to end up into the bloodstream. Whether it's 75 or 100% or somewhere in between is going to depend on how well that drug dissolves and diffuses through the tissues into the blood. Good thing about intramuscular as well is that you can give big volumes, but it's an injection, it can be painful. Subcutaneous injections, similar to intramuscular, you will have quite a high amount of the drug, a high bioavailability, high amount of drug reaching circulation, a high bioavailability. You have to use smaller volumes though than for intramuscular injections. Rectal administration will avoid some degree of first pass effect. Not all of the blood vessels around the rectum go into the hepatic portal system. So you're going to have a higher bioavailability, but you're still going to have those other issues of it might actually be passed with feces before it's all absorbed. Inhalation, It's going to vary greatly depending on the drug's chemistry. So how well it gets into the air, how well it gets deep into the lungs, and how well it crosses the membranes of the alveoli, crosses the cell membranes of the alveoli. But you can often get very rapid onset of action. And transdermal, as long as you've got a lipophilic drug, you can get quite high bioavailability and quite prolonged action.